Hi, today we are going to be studying the assessment of the obstetric patient. So most of this is going to be about history taking. There's no special fancy tasks to do. We're not listening with our stethoscope to the baby's heart or anything like that. As paramedics, we don't do that. We don't get trained in that. So if somebody asks you, oh, can you detect a heartbeat or whatever, don't bother, we don't do that. So let's go to this book. If you got that one with you or got it handy, that is what we're going through today. Now, as you can see from this book, there's not a great deal in here for the obstetric assessment. It's mostly going over what we've done before, a bit of history taking, and then looking at the red flags. So it's kind of an easy one in terms of trying to remember what to do. But at the same time, there's so many red flags and it's really important. So it's the kind of one that if you were RuPaul, you would say, don't it up. So let's move on anyway, and let's tell you what we're going to do today. So as usual, we'll start with the whole introduce myself, game, consent, danger, all that kind of stuff. Taking a general history of the patient, so the patient being the pregnant female. We're not concerned about the birth of the baby at this stage. This is pre-birth. So general history, how she's feeling at that particular time. Looking at her observations, so her normal vital signs, understanding what changes really about the anatomy and the vital signs during pregnancy, and then looking at the red flags. So the red flags tie in with everything else we're going to be looking at here. So all these other points are conditions that could happen, could lead to serious illness or death. For you, I need you to be aware of these. So there's no homework that comes with this. We're talking about all the conditions within the lecture. Because we're not necessarily going to go over the vital signs and the history, etc. again, we're going to be looking at specific conditions. So miscarriage, ectopic pregnancy, preeclampsia and eclampsia, hemorrhage, that's first of all the antepartum, pulmonary embolism, then postpartum hemorrhage, the mental health, postnatal depression, and maternal sepsis. So this could be quite annoying to some people. Why did I put pulmonary embolism in between antepartum and postpartum? It's just to break it up because I don't want you thinking antepartum and postpartum can happen simultaneously or are the same kind of thing. So I've dumped PE in the middle there so that you think of some before birth and some after birth. Okay, so general history taking, vital signs and red flags. These are the sort of things that you're going to be doing. So come into the room, as usual, we're checking for danger, we're checking for response. Hi, my name's Gemma, I'm a paramedic. What's the problem today? Doing her A, B, C, D, E. So patient replies to me, she's got a patent airway. Looking at her from across the room, I can see her breathing rate seems to be within normal range. She doesn't look like she's struggling. No strange noises that I can hear. Circulation. Does she look pale? Is she sitting upright? Disability, is she moving all four limbs? Does she seem like her GCS is 15? Any altered mental state? Any medical illness, maybe making her less aware, less conscious than normal? E, exposing environment. So for this, we're going to be probably looking at environment first of all. We are going to be checking for any clues that might indicate what's going on with her. You won't see an awful lot necessarily in this. When we looked at respiratory, cardiovascular, there were a few more clues, but for the obstetric assessment, there's not a great deal that we can be seeing from the clues that are around the environment. In terms of expose, if there's trauma, yeah, definitely. If the patient's suffering an abdo pain, then you can have a look. But a lot of the time, this is not going to be about IPPA or anything like that. It's going to be about excellent history taking and considering red flags. So checking the environment, checking the patient over, asking about her contractions if she's having any contractions, whether she's, what gestation she is in her pregnancy. So as we discovered the other day when we did the talk about the newborn, we're looking at normally viability, as in the baby to survive after 24 weeks. But as we discovered, you can have some type of effort, respiratory effort, or some babies that might make it under 24 weeks. So we're being a little bit loose about the fact that we think a baby is viable at 24 weeks. I'll say 22 to 24. So we're finding out how far along the patient is. If the patient is like towards the end, we're preparing for a birth. Ask about contractions, about pains. All right, so this is very quickly going to go one of two ways. It's going to be about to have a baby or not about to have a baby. Okay, so you can think about it in those two ways. For the most part here, we are considering not about to have a baby because you will go through birth, the assessment of the patient who's giving birth when you do it in Richard's course. So we're talking about emergencies, cord emergencies, baby positional emergencies, and normal birth, etc. This isn't about that. This session is about what happens around birth, before, after. Right, so as usual, introduce yourself, gain consent, make sure it's nice and warm, private, that you've got a good space to talk. The patient is nice and calm and comfortable, and that you're going to be able to have an honest, frank conversation with her. So if you're in a situation where there might be parents onlooking or abusive relatives or anything like that, you might want to take the patient to the ambulance so that you can have a private talk. We're going to take a general patient history. So as usual, like we did with any other assessment, what seems to be the problem? Okay, so the patient might talk about pain, they might talk about bleeding, they might talk about breathing issues, they might talk about fainting. There's so many different things here that the patient could present with. So we're just going to go through the medical model. So we're going to look at the presenting complaint, the history of presenting complaint. We're going to look at what we find on examination. So if it is a respiratory issue, get your steth out. In general, like I said, you're not doing this on every single assessment of the obstetric patient, but there are certain ones that you will. So on examination, any type of social history, surgical history, any type of family history, review of the systems, of the other systems, and then just bringing it all together. You might need to do a pain assessment tool. So as usual, we usually go on with Socrates for this. If a patient is having pain and it's not labour, then Socrates is fair enough, or OPQRST if you want to do that. If the patient is having contractions, I wouldn't go about doing Socrates in such a way. I would be timing them and I would be giving her pain relief. And then afterwards, you can kind of go through Socrates once you've got it managed a little bit. But for the patient who's not in labour, Socrates is fine. I've put MG threads in here. Remember what MJ threads is for? It's for going through to see if there's any previous medical history that the patient might not have told you about. So as usual, we say to the patient, okay, so tell me about past medical history. Don't think I got any. Okay, and then once you get to the hospital, they got a ton. So to save ourselves that bother, we ask specific questions. Have you ever had a heart attack? MI. Have you ever had jaundice? Have you noticed any yellowing of your skin or your eyes recently? Have you ever had TB, etc.? So have you ever had with MJ threads? After that, we are going to go through the maternal history. So like I said in your assessment of the newborn and the neonate, I want you to have a look at the notes. So we want to be looking at the notes through the pregnancy. If this is post-birth, we want to look at the notes the whole way through and the birth notes as well. Have a good flick through. So you have done vital signs. Okay, you haven't done the vital signs yet. All right, so patient notes, hold them in your hand. We can have a quick flick through now if you want, and then we can have a little look at the maternal. Sorry, I've confused myself. We can have a little look at the vital signs first, check if it's time critical, and then have a proper look through the maternal notes. So I really should change this so the vital signs are above the maternal history. When it comes to vital signs, what are we looking at? What are you going to look at first? What's the most important? Okay, so I tell you this in every one of the assessments. If this is your OSCE, you've got to think about how is this presenting and what order do I want to do my observations in. So, for example, if it's a bleed, you're probably going to want to feel the pulse first on the radial, and then you're going to want to take a blood pressure. You're looking for signs of shock. If it's a query infection sepsis, you might want to do the respirate and the SATs first. If it's a collapse, you might want to do a fast test, or you might want to do a blood glucose test. So you can figure it out from that. Get a full set of obs. Is it worthwhile doing an ECG? I mean, at this stage, not usually, unless they're complaining of chest pain. If they're complaining, if I've got a pregnant patient or a patient that's just given birth that's complaining about chest pain, I'm probably going to be thinking in my head PE more than cardiac. So I will do an ECG eventually, but it won't be the top of my list. We'll talk more about ECGs when we come to PE, so try and remember to yourself what a PE looks like on an ECG. Right, so just to recap there, we're doing our initial hands-off approach, the end of bed assessment. That's the Dr. ABCDE in the primary survey. We're looking at patient comfort, patient dignity, privacy, introducing ourselves, being polite, all that stuff. Taking a general medical history. Then vital signs. And then we're going to take a maternal history. So after the vital signs, after you've gone, right, okay, this isn't time critical, I'm going to need to ask some more questions, but we're not whizzing away straight away in the ambulance, then we're going to get out the notes and have a little look at the notes. So we want to know everything about the birth. We want to know what has gone on, about the pregnancy, what has gone on up until this point. And if it's post-birth, we want to know how the birth was as well. So how long was the delivery? Was anything used to facilitate the delivery as well? So parity and gravida. Do you know what they are? Pause the presentation and try and figure out what is parity, what is gravity. Okay, so just double checking my notes to make sure I say it right. So with gravida, that is the number of times that the patient has been pregnant. So that includes any type of birth, miscarriage, anything at all, the amount of times the patient has been pregnant. Whereas parity is the amount of times that the patient has given birth. So when it talks about giving birth, that's the amount of fetus that has been born. So that does include stillborns. When it comes to gravida, that includes the current pregnancy as well. So if the notes said about your patient G3P1, that means she's been pregnant 3 times, including the current pregnancy, but she's given birth once. So you can ask her, okay, do you have any children? If she says no, then you'd be thinking, okay, what is that P1? Well, the P1 could have been a child that was not born alive, for example. And there's sensitive ways of asking about that. So ensure you know what G and P are when it comes to the medical notes. Have a look at any risk factors. So any previous complications in old births, any risk factors such as family history, such as fetal history as well, multiple births, for example, breech births, anything that it will tell you about what has happened to her in the past that could be happening to her again at the moment. It is very necessary and very relevant to find out about previous obstetric history. Any type of birth complications as well, that will be noted down in the maternal notes. All right, so we've done all of those things. Now we're going to move on to something that is a little bit more specific. We're going to go through the key conditions that this patient might be facing. So first thing I want you to think about, and I'm going to want you to present questions to the patient on, is the possibility of miscarriage. So first thing you're thinking is, when does a miscarriage actually happen? So the majority of miscarriage are going to happen in the first 12 weeks, the majority. But the definition of miscarriage can be anything up to 24 weeks. So anything up to the viable age for a baby. So if the patient is in the third trimester, for example, that's not really what you would call a miscarriage. So miscarriage is before 24 weeks. Right, so now that we've got the definitions out of our head, what kind of questions do you want to ask? Well, I've put some of them down here. So, is there any pain? Now, you can either go through Socrates again, if you want, or you can ask more specific questions. So, where exactly is the pain? And is it definitely located to a pregnancy? Is it definitely pregnancy related? You know, there might be a pain in there, the patient might be pregnant, but there might be something else going on. For example, like a cholecystitis. There might be UTIs that are to do with the pregnancy. So it's still located within the whole pregnancy, but is it related or not related? That's what you want to think in your head. What else could it be? Okay, so whether it comes across as pain or it comes across as bleeding, you're thinking the whole time in your head, is this definitely a miscarriage or could it be something else? So at some stage you're going to have to do the pain assessment tool, whether it's right here in the bit where you're thinking about miscarriage or whether you've already covered it in your previous assessment. It has to be done somewhere. Should you give any type of pain relief? Well, that depends on the condition and depends on how it's presenting. But when you go to think about pain relief and give pain relief, definitely must check up your GIR calc. So, for example, it might be that morphine could be given for severe pain. However, oral morph shouldn't be given. So please don't just assume that you know these drugs. Check them up because there's going to be something in the cautions or the contraindications potentially about pregnancy. And that goes along with everything. I'm talking aspirin, I'm talking paracetamol tablets, ibuprofen tablets. Check them all up, even salbutamol, even oxygen. Just don't rely on you thinking that you know what the contraindications are. But there's no reason not to give pain relief if it's not contraindicated. Obviously, you can bring in shared decision making here, so you can tell the patient, yes, there are risks involved with taking aspirin with pregnancy, and let them make the decision. Just make sure you document that. Miscarriage normally comes along abdominal pain and bleeding. So the patient might present to you with abdominal pain. They might not necessarily present to you with, I think I'm having a miscarriage. They might present to you with bleeding and not necessarily, I think I'm having a miscarriage. But for anybody who's having bleeding and they're of childbearing age, you've got to be thinking about miscarriage. Whether they know they're pregnant or whether they deny being pregnant, you can still think about it. Right? We know from our abdominal assessment that if you're taking the contraceptive pill, don't matter, you can still get pregnant. If you use the condom, don't matter, you can still get pregnant. So being polite about it, but thinking in your head, okay, this person's bleeding, they've denied that they're pregnant, it can still be a miscarriage. So let's ask a few more questions about the bleeding. What's it like? All right, that sounds gross. Maybe don't ask it like, oh yeah, tell me more, what's it like? Maybe just say, okay, what color is it? Is it, what is the consistency? Because when you're thinking about miscarriage, we're thinking about the cells of the fetus forming and we're thinking about the fetal development. And so if that fetus is being passed, quite often you're going to see it in the form of clots. Now, the clot doesn't come out looking like a part of a baby or anything like that, really, normally with a miscarriage. You will just see blood clots within the blood. And I know that can be normal for some people during their menstruation, but we'll ask the patient, is that what a normal period looks like for you? You know, if they think it might be their period. Ask about the colour of it. So we know that When there's fresh blood, that is bright red. We know when there's like older blood, that's more dark coloured. So if there was like a dark coloured blood and there were little lumps in it, that could be a miscarriage. Okay, we're thinking about quantity as well. So thinking about uh, what gestation it might be at if they know they're pregnant, how much blood should come out in a miscarriage, how much of it is bleeding, how much of it is the fetus passing. So try and get an estimate from them. Now, you won't get an estimate in terms of milliliters. That just won't happen. You'll get an estimate in terms of pads. So how many pads have you gone through? Pad is basically a big sanitary towel. So if you pour in like 50 milliliters of fluid into a sanitary towel, that would soak it through. So we're thinking about how many pads. And this is how midwives think as well. So when you come to the hospital and say, oh, there's been significant bleeding, they'll say, well, what's significant? How many milliliters? And you could say, well, I don't really know, but she's been through 8 pads in the last 1 hour. And that means, oh, she's bleeding a lot. Is there anything else that could be causing this bleeding? So think to yourself now, you can pause this again. Think about it now. What else might cause vaginal bleeding? So we know that infections can cause vaginal bleeding. So that's bladder infections, kidney infections, urinary tract infections, ureter infections, and a lot of sexually transmitted infections. So yes, it is a known fact that when people are pregnant, they still have sex and they might still be having sex with other people too. So don't rule it out. Don't think, yeah, just because she's off the duff, she's not having it off with anyone. More for you. So any other potential causes of the bleeding? Loads of things about infection. What about trauma? We don't know what's going on here. We have got to think of sexual assault. We've got to think that that still can happen when people are pregnant with their partners. They can still be victim of rape and sexual assault. So is it possible that the bleeding's from something else? Again, that's going to it's going to help you to figure out if it's some type of trauma or not by the color of the blood. So if you're thinking about the browny kind of clotty blood, then we're thinking old injury. Clots can be red, they can be purple, they can be brown. Clots are different, wouldn't necessarily come with trauma too much. What trauma would look like is probably bright red blood. So we're thinking of the characteristics, the quantity, and any other potential causes. If a patient has suffered with miscarriage before, it is possible that they will be more susceptible to it in the future. If the patient has had IVF, for example, that also increases the risk of miscarriage as well. When a patient does have miscarriage, quite often they become a different type of patient as well. So instead of just having to look after their medical needs, you quite often have to look after their emotional needs as well. So this can be quite a complex case. You've got to think about miscarriages as well as in progress. So it's not the kind of call I would necessarily leave at home, because miscarriages can be full or partial. The person would be like, they could be like, oh yeah, will the bleeding stop now? And you might think, okay, the bleeding stopped. That is the fetus out and they can get on with their life. What's the point of bringing them into hospital? Well, if you think about the part that might be remaining inside and how that can get septic and then cause septicemia through blood poisoning. So with miscarriage, I wouldn't leave it at home. Okay. There's a little bit more information I've put around here. Obviously, I'm not going to click it in now while during this lecture, but on the static version, go through that and find out more information about it. Next topic, ectopic pregnancy. Now, we know this from the abdominal system, don't we? We know about shoulder tip pain. We are all experts. Someone says shoulder tip pain, we go, anytime you might be pregnant. We know that. Let's know a little bit more about it. And I want you to be looking at these bits, like I showed you in the last slide, these extras. I want you to be extra about pregnancy. So, when it comes to ectopic, when will that typically occur? Do you know? Okay, well, I know because I wrote it down. It's usually within the 4th to the 12th week. So, first trimester is usually when we see ectopic pregnancy. Do you guys know what it actually is? You know, we band around this phrase quite a lot, but some people aren't really sure what an ectopic pregnancy is. So, if you don't know, it's time to pause and look it up. And that's the same with everything. Anything we're talking about and you think, oh, I think it's this, I'll check later, sure. Pause me now, check me up immediately. What's ectopic pregnancy? So essentially, this is a pregnancy that's not growing within the womb. It's normally growing in the fallopian tube. So what will happen is quite suddenly, the patient will develop pain in one side of their abdomen. It's quite low down. So you think about the fallopian tubes. Now, I don't know about you, but I thought they were probably about that size. I thought a fallopian tube was like, woo, about the size of a spaghetti or something like that, maybe a bit wider. But teeny tiny. They're really, really small. Anyway, so the cells start forming in the fallopian tubes because, of course, don't forget, 4 weeks, the baby's just a number of cells. 12 weeks, they're a little blob, aren't they? You know, they're a little satsuma sized kind of thing. So that inside a fallopian tube will block it. So let's think about how it presents. First of all, is there any pain? So with ectopic pregnancy, you will always have pain. When it first starts, like I said, with the cells and all of that, it's it can go with no symptoms whatsoever. People might not know they are having an ectopic pregnancy until they get a scan. I think it's a transvaginal scan that they would have to get for that, an ultrasound that goes up instead of on the skin, um, because it's so minute. But people normally realize that they're ectopic because either they've been before or because they present with something. So just because they're presenting as asymptomatic doesn't mean they don't have it. So I want you to think about this as something that is potentially fatal, because it is. If this baby is growing in your tiny little fallopian tube and it gets big enough, the fallopian tube will rupture. It will burst, it will rip open, and that can cause serious bleeding. So this can cause death. So I want you to always be suspicious about ectopic pregnancy. With any woman who's of childbearing age, if there's any chance, keep it in your head as a differential. Right, let's talk about the two things as usual, pain and bleeding. So pain. Where is the location of the pain? Like I said before, it's normally quite low down in the tummy and it's either one side or the other. All right, if you have a woman that comes on with pain like that, you could be thinking ectopic. Referred pain. You guys know this. It's going to be on the shoulder tip, and it could be on either shoulder tip. Consider alternative diagnosis. Well, of course, we're always going to be doing that because in this module, you know you want more than one differential. So we're going to be thinking, oh, what else could cause pain on one side quite low down? And we'd be thinking maybe appendicitis. Loads of options. And this would be the same in your OSCE, by the way. You know, if you were to get an OSCE on obstetrics and she presented with a right-sided pain, there's absolutely nothing wrong with you saying, right, I want to do some appendicitis tests and putting appendicitis in as a differential diagnosis. It's fine. You know, you can have both. It's all right. Okay, so considering alternative diagnosis, using your Socrates again to do the pain assessment tool. Yet again, should we give any pain relief? Why not? So when you're looking at ruptured ectopic pregnancy, this is the kind of situation where you do not want to be given morphine. Because morphine's going to depress the central nervous system, that will work on your parasympathetic system and that will bring the blood pressure down. So if you have a rupture and you're bringing the blood pressure down again, that is going to make the patient collapse. That's going to be bad news. Okay, so the bleeding. Now, usually there's not going to be any visible bleeding here because it's inside the fallopian tube. So we're going to have to think about other ways of finding bleeding. What other kind of way can we detect a concealed bleed? Well, firstly, pain. All right, we've talked about where the pain is located, but secondary to that, what about your vital signs? How are you going to notice a bleed in your vital signs? So we got pulse, might be weak and thready, might be high. Blood pressure, systolic's probably going to be low. Resps, they might rise and then fall towards the end. Temperature, blood glucose, and they're not really getting affected. GCS, yeah, maybe they'll drop a point or two. Not cap refill, yeah, cap refill. Pupils, yeah, pupils. This is how we're going to see blood loss. Remember when you did your BLS in first year, we talked about hypovolemia as one of the reversible causes. We're looking for signs of hypovolemia. So all you did was you rushed to the abdomen and said, oh yeah, abdomen's now soft, and you're asking any rigidity, all that kind of stuff. If you've got an internal bleed, you might feel a little bit of rigidity there. But don't forget there's a baby in there, so you might be feeling something a little bit strange anyway. So take on all of the clues, especially Capri foot. Any other potential causes for the bleeding? As always, we're thinking about infection, trauma. So plenty to go on there. Don't forget little things that you can bring up from the other lectures. So remember about Gray Turner down the sides. Remember about Collins around the umbilicus. So think about how in our abdominal system we went over ectopic pregnancies quite a lot. All right, I'm going to pause this recording now because I'm sure you can tell I'm getting really dry. And when someone gets dry, I personally can't listen to them at all. All I hear is so. I apologize that this is in two parts, but boy, I need a drink of water. Adios, amigo.